So basically, this is an area where there is a lot of ambiguity regarding whether after the RT, whether there is still a residual disease or there is a post-RT radiation-induced changes. So these are sometimes technically difficult to deal with, and especially if the window period is early, maybe a 3 or 6 months of the time period. And this review has highlighted that there are some other parameters which we have to look, and a multimodality imaging, how it will work in this scenario, it has highlighted this scenario. So basically, we all know that relay or radiation-induced lung injury have almost similar patterns in the early follow-up period post radiation. So these are the things, and in this we try to evaluate the radiological features both on the conventional CT and the FDG parameters to predict whether there is any local recurrence, or to evaluate whether radiomics also has any role in detecting the local recurrences. So in that they have included the patients with the NSCLC. They have seen that whether there is any one part of the area that has been given SBRT or multiple parts, or whether there are any local recurrences, and they are treated with the SBRT. And what kind of the modalities they have used, either it is a CT, FDG, PET CT, or they have done with the radiomics. So exclusion was there when there is don't have any reports on the radiological characteristics post SBR, or reported only pre-treatment findings, not as a post-treatment changes, and studies they don't have a LR as a separate outcomes. So basically they have done their research from Medline, Embase and PubMed databases for all the eligible data sets, and they try to include even the conference abstract, and they try to remove the duplication where the abstract, if it has already been published in that aspect. So after that they have come across 32 studies with an approximate median follow-up interval of 24 months in almost 84 cases where these are biopsy proven. And out of these 32 included studies, 19 reported the radiographic findings on FDG PET, 14 on CT imaging, and 3 on radiomics. The thing is that the local recurrences have multi parameters. They are either proven by biopsy, or either they have done a sequential imaging, or by MDT they have taken the local recurrences into the account, because it is a retrospective study, so it has been review, it has been designed in such a way. The main thing that they try to classify CT features pre 6 months post treatment and post 6 month treatment, in which the chances of radiation induced changes are relatively higher, like diffuse consolidation, patchy consolidation with some ground glass opacities, and diffuse plus patchy consolidation in different studies. And in later stages, it is usually a fibrotic pattern where it is a mass-like fibrosis or a scar-like fibrosis. These are the things which has been evaluated on the CT. But apart from that, what they have predicted that the main parameters are not those. So they have come up with the new criteria that is in this particular review is the high risk features that we have to look for when the patient has been treated with SBRT. So basically regarding whether there is a bulging margin on the sequential scan, there is loss of air bronchogram if that is occurring at the site where there is a pneumonitis, and whether the lesion has been enlarging after the 12 months of the period, or there is a linear margin disappearance or progression at linear margins, or there is an opacity which is enlarging at the site of the primary site. More important is that whether there is any craniocaudal growth is there, or there is a new effusion that is coming up, or there is a new mass or new node or things like that. So according to their suggestion is that if we combine the high risk features, the sensitivity might drop, but the specificity will rise. So we have to draw a cutoff about how many high risk features we can take. So they have decided to take at least 3 high risk features in which the sensitivity and specificity both can be matched and give a good reporting outcomes. In the PET CT modality, they have taken a criteria of SUV. So after the SBRT, there is an intense inflammation, but the inflammation subsequently will go down in the follow-up interval, but however, it will not so drastically change in case if there is a residual disease or there is a early recurrences. So their recommendation is that the timeline they have decided is about the 12 months instead of the 6-month sequential CT scans people do. So within the first 12 months post SBRT, if there is a reduction of less than 5% from the baseline, then it has to be taken as a probably there is might be a residual disease. If something which is a significant drop in that areas, then it has to be taken as an radiation-induced changes. And apart from that, we have to match these features with the CT features like mass-like areas are there or not, or what is the kind of uptake in that areas. In the CT, within the 6 months, that is the usual time period follow-up people will do. We know that the radiation-induced changes are there in the earlier first 6 months that are like patchy consolidation and GGOs and diffuse consolidation. After 6 months, we have to focus whether it is having a fibrotic changes, traction bronchiectasis or some other opacities, or whether if there is a nodule, whether it is increasing the size, or there is a bronchogram which is filling and giving like a mass-like pictures. So if there is a 3 consecutive scans which will show increase in the size, then it has to be taken as a progression. The main thing that this review highlights is the high-risk features, and in high-risk features, these are the connotations they had designed. If there is a bulging margin, so if there is a nodule which is the margin is increasing, it has to be considered as an recurrence or might be a residual disease that has been left behind in the background of the radiation-induced lung injury. And if there is a loss of air bronchogram, if there is a pneumonitis change which has filled with the air bronchogram, and whether there is any increase in the craniocaudal extent and the sequential enlargement of the lesion. So just I have taken a few cases from the department. So in this case, we know that this has been given SBRT, and subsequently we will see that there is a reduction in the size of the lesion, and subsequently it remains the same. So this is a classical post-RT scenario, and there is a no locoregional recurrence in that. Again, it is a regressing radiation pneumonitis. We can see that in this case, we will see that there has been a normal period, but somehow in the second, the post-RT changes have come in a later stage. In this, there was a progression in the background of the radiation pneumonitis. We see that there is a nodule which has remained stable for quite some time, and then subsequently it has enlarged. So basically the margins are bulging, the mass is increasing at the site where there is a primary. So these are the typical findings which will tell about the progressive disease in these scenarios. So the highlight of the paper is that we have, instead of RECIST, we have to talk about the high-risk features when we are talking about post-RT changes, both in the CT and the MR. And the cutoff period, instead of 6 months, it has to be 12 months. The limitation of the study is that it is a review is that it is a retrospective, and there is no common lexicon that has been provided. So we need a new prospective study with a larger data set and with a common lexicon terms that can solve these issues. So thank you so much.